Welcome to the Dr. Geo Podcast. I am your host, Dr. Geo, where it is my goal to help you with your prostate health and how to live better with age. We have Chris Kelly from the NYU Langone Urology Department. Chris, thanks for being on. I know you did rounds this morning and you kindly chose to be on the show, so I really appreciate it.
It's always my pleasure to spread the word. Thank you very much for having me.
My pleasure, Chris. Chris, BPH. So, first of all, my understanding of what you do at our department is that you're pretty much a general urologist. So that means you can probably see anything that comes in. A, correct me if I'm wrong. B, I do know that you do a lot of BPH. So are you a more of a BPH urologist or are you a general urologist? What would be your specialization, if any, at this point in your career?
My specialty in the practice is avoiding dysfunction in the male,
Yeah.
okay, which incorporates a lot of BPH related voiding disorders. But I'd say a general urology sort of a subspecialty is, I can wear that hat too. Things come into the practice, little things that are not quite a huge category. Uh, and I'll see them, and it's great. I feel very comfortable with a wide breadth of disorders.
So if a kidney stone scenario comes in, you don't have to refer them right to Dr. Boren or Zal. You can take that on yourself, you think, or you'd like to?
Well, in my 23 years in the practice, sure, I'll do them on call, but my practice is so filled with a lot of BPH that I probably would offer my colleagues the chance to help the patient because they're probably are much more available to handle a kidney stone in the operating room than I would because I have so much BPH. I can't handle it.
Right. So BPH is what I certainly know that you do a lot of, and I think that just kind of it seems like it took when I first started at NYU about 13 years ago or so. It's like time flies. You were more of a general urologist. You did some ED. You said you did a lot of prostatitis at the time, and then I guess that life takes you in a certain direction, right? So if you just start seeing a lot of BPH, you start becoming honing in your skills in that area. Is that sort of what happened that now probably most of your practice is related to male urinary dysfunction?
Well, yeah, it is true. Now, people don't usually come in to see me always with a clear cut diagnosis. For example, they come to see me with they think it's BPH, but it's prostatitis. So my job is to sort of sort out what is what here.
Great.
So I will see a lot of people with urinary problems that are male, and I have to sort of figure out is this a prostatitis thing? Is this a BPH thing, or is this sort of a compound problem, or is this male pelvic pain? Is this something beyond, those two diagnoses? Is this pelvic floor dysfunction?
Right.
Or is this a kidney stone, or is this something, much, much greater? So it's, hard to sort of, but I will see people with symptoms, quote unquote, down there, and I'll sort it out from that point.
What's your process, Chris? So here's why I asked, right? We know that a male patient can come with urinary dysfunction. So urinary frequency, urinary urgency, etc., nocturia, right? Nighttime urination. And what's your process to differentiate between prostatitis, between BPH, or overactive bladder? Not long ago, I had Dr. Bilal Shatai here on the podcast from Cornell. And my question to him was, and I'm going to relay that question to you as well. In that older patient that I feel that oftentimes they come in with urinary problems, older, whatever age, let's say 60 years old or 60 and above. They come with urinary problems, and oftentimes they're diagnosed quickly with a prostate problem, despite the fact that they have a bladder, and oftentimes it could be overactive bladder, probably in some cases unrelated to the prostate. So, Bilal, in a very tongue-in-cheek way, said, "Well, you have to blame the organ you have. So if you have a prostate, it must be the prostate, right?" So, what is your process to differentiate between a patient that comes in and was like, "Wait a minute, is it prostatitis? Is it overactive bladder? Or is it BPH? Is it a combination?" How do you go about that?
Well, when patients come to see me with these symptoms, these are called LUTS or LUTS, lower urinary tract symptoms.
Right.
I usually will start to think of them as irritative or obstructive symptoms. Now, the irritative symptoms are typically traditionally urgency, frequency, um, and the obstructive symptoms are typically decreased force of stream, a sensation of incomplete emptying, double voiding. These are sort of the symptoms of obstruction. So, an overactive bladder person, or a person with prostatitis and a person with BPH can have all of these symptoms, right?
Right. Exactly.
A person with so for prostatitis, it's usually something which has been something that happened out of the blue. It happened, you were fine, really. And all of a sudden, and it could be a trigger event, such as a lot of sexual activity, bicycle riding, even a colonoscopy where the prostate can be pushed on a lot, or constipation. These are things where you feel, okay, this is more prostatitis, because of the temporal nature of everything, and that's treated a whole different type. I won't go there and how that's treated, but that's how you kind of sort the diagnosis. For between BPH and overactive bladder, that's where it gets kind of fun for me,
Okay.
because people with overactive bladder, they tend to have no problem with urinary flow at all. They'll tell me that they have supreme urgency, that they will knock somebody down to get to the bathroom, or just always going to the bathroom with frequency. It's not so much of an obstruction of a problem. The person with BPH will have this sort of like, my flow is not the same as it was. Now, adding to this is that there's a lot of overlap between overactivity and BPH obstruction. Okay. So who come to see me with a very obstructing prostate can have clear overactive bladder, and the person, or not, they might just have a slow urinary stream and incomplete emptying. So here's what I do. If I am hearing a patient, let's just exclude the prostatitis. This has been going on for years, let's say, these symptoms. And I hear in their symptoms and it sounds like overactive bladder. The stream is good. I'll check their post void residual, which is a simple kind of a test in the office where the patient goes to the bathroom and does their best to empty. They don't try too hard, but they just do their regular. And they come back and I had them lie down on a hospital, on a clinic bed, and I measure the amount of urine still in their bladder. If that's very empty, that will give me a potential, that'll lead me more towards overactive bladder. But if it's sort of full, there's interpretation in that, that I will think about maybe obstruction. Now you may say, so it's all kind of matters about how much they have in their bladder. Well, not exactly. If I am still, in a way, not clear about what they have, overactive bladder versus BPH obstruction with overactive bladder, I will do a very special test in the office, which takes me about 15 minutes, called Urodynamics.
Yeah.
Urodynamic is a great test that people can do with their urologist or their urologist practitioner to uncover the real reason behind their symptoms. And this is the gold standard way that a person can be kind of really clearly diagnosed. Okay. I have patients where I caught clearly they had just overactive bladder, but in fact they had obstruction with
Right.
overactive bladder.
So
And
you can indeed have both. You can have BPH, which
you
causes
clearly can.
obstruction,
Yes, you clearly can.
and you can have overactive bladder.
Yeah.
I want to pause there for a second, and you spoke about one of the clinical ways, easy tests to do to differentiate between overactive bladder and BPH is the post void residual. Easy to do, inexpensive. You can see how much urine you have in your bladder. Chris, what's a good number for you? And you said because that's due to interpretation. So let's say the patient they go urinate, you come back and they have some urine in the bladder. At what point would you say, "Yep, that's a problem," and at what point you would say, "Well, they do have some urine in the bladder still, but that's not really a problem." What's that magic number?
Okay, so there's no magic number, but most urologists will actually, feel okay with post void residuals under about 100. cc's or milliliters. Okay.
Right.
You know, this is a lot about gathering information and coming up with a clinical impression. This really is not a cut and dry diagnosis with just a few simple, quick tests in the office. The only one which will really, I think, settle an argument is the Urodynamic study. But but aside from that, when you're hearing the patient, when you're palpating their abdomen, when you're doing a post-void residual, you're left with sort of a clinical impression, and that's you know usually if you're good, you could be right. But again, if you really want to check yourself, you go with the Urodynamics. One more little wrinkle in this thing is that people's slow flow and feeling of incomplete emptying and that high post-void residual may in fact not just be due to a big prostate. I may add that it could also be due to a underactive bladder.
Excellent point. Talk a little bit more
Okay.
about that. Yeah.
That's where the bladder, for some reason, okay, either it's caused by the nervous system problem or by bladder fatigue, okay, from long-term distension and long-term obstruction. The bladder does not actually squeeze. Okay.
Right.
And therefore, this urine is very slow. The bladder doesn't empty. Okay. It could be a real problem.
So
So
underactive bladder, of course, is the opposite of overactive bladder. And by the way, I've seen that clinically as well. Interestingly, so this is a patient. The clinical presentation is actually fascinating because they would say, "Well, I urinate fine." IPSS, which is a questionnaire to determine how good a male is urinating or determining LUTs from a prostate problem perspective, is not that high in some of these patients because their perspective is, well, I'm doing, I'm doing fine. But then you do a PVR, post void residual test, and they have 400, 500, 600 cc's in their bladder.
these
Oftentimes, that's a result of underactive bladder, and I've seen that a few times. How common is that in your practice?
it's fairly common. I mean, as the population gets older, okay, as the population develops neurodegenerative diseases such as Parkinson's or otherwise, as the uh, people get more years of unattended to obstruction. I see this more often with my patients. Now, adding to this, okay, I'm going to really add some zest to this conversation.
Go ahead. And by
One
the way,
thing,
Chris, it's okay. We're just recording here. It's your light went out. I don't want that. Don't worry. Just keep going. You look
oh,
great.
good. I like talking about urology in the dark too. Okay. So you can also have an overactive bladder with an underactive bladder.
Oh,
Now, you may
say
say,
more.
"What?" Well, this is when these are patients who have what we say a quivering overactive bladder that gives them the need to go to the bathroom, need to go urinate very often, and when they finally do urinate, it's just not a good flow because the bladder is underactive.
Yeah.
So you have this sort of almost like a bladder, if you will, to use a cardiac term, in atrial fibrillation in a way
Right.
that has no real ejection fraction.
Yeah.
It's
Exactly.
very kind of poor. It's like dilated cardiomyopathy with atrial fibrillation. You see, urology and cardiology are very similar. We deal with these hollow organs that pump fluid.
Right.
So the whole thing is so fascinating to me. It keeps me on my toes throughout the day. I love it.
Even
I
after
love it.
23 years of
Oh
doing it,
God, I
you
love
never,
it.
you never get bored.
No, I never get bored.
So this is a situation where you have urgency. I have to go. I have to go. But you don't have, for whatever reason, the muscle of the bladder is just not squeezing to let the urine out.
Yeah,
There
that's
again, this is where you would probably benefit from a urodynamic, right? So clearly, that's a key component to differentiating in your practice. But Chris, not everybody gets a urodynamic, and let's come out of your practice a little bit here. Let's go in, general to what other urologists either do have access to? Because I just don't see everyone just getting a urodynamic for whatever reason. They just
Oh,
may not
clearly
have
you
it.
don't. Yeah. No, not everybody needs a urodynamics. I mean, for the person who is visiting the urologist and says, listen, I've been on this medication called an alpha blocker, and they go by many names. And
What are
if,
some of those names, Chris?
well, by generic names, they're tamsulosin,
Mm-hmm.
silodosin, or
Mm-hmm.
alfuzosin.
Mm-hmm.
There's doxazosin and terazzosin. Okay. But
Right.
those are just the generic names. We know them by Lomax or Rapiflow,
Right. They're brand
Urology,
names.
Cardura, and Hydrant.
Yeah.
If they say, listen, whenever I take this medication, I am so much better. I don't wake up that much at night. My flow is better. They're most likely obstructed. There's no need for urodynamics with that one.
Right.
However, if they don't respond to the medicine or if it's well, if they don't respond to medicine or if they don't tolerate the medication at all, you're sort of left with questions and you may want to do urodynamics after that.
Tell us that process. So what's urodynamic? The patient. What happens to the patient? I know there's what facility do they go to? What room do they go to? What's that process like?
Okay. So a urodynamics for a man, okay, we're gonna take that.
Yeah.
They're pretty thin, but I'll talk about the man who ambulates. Here's how it goes. Basically, you come in, okay, to the office, having had a bowel movement, hopefully that day, and a urination, okay. We bring you into the urodynamics suite, which is a little room with some X-ray equipment and a urodynamics console and a monitor, and we basically lay you down, okay.
So they're with a gown, right? They don't have their clothes on.
Oh, you're with a gown, yeah, you have little booties on your feet, not a big deal. We make you comfortable,
Yep.
and here's what we do: we have to place and the word will send shivers up some listeners' minds, but with a catheter. And
Yeah.
the catheter is very thin. The catheters are the size of a spaghetti noodle.
Right.
Okay. And one is slid up into the bottom, and one is slid into the penis, into the bladder. Okay.
So
They're
one
two
is through the
separate.
rectum, and the
Yep.
other one is through the penis.
Yeah. No, these are special catheters. Okay. They have little tips on them that sense pressure. Okay. The one in the bladder, of course, has that, but also has another port through which you can infuse liquid. Okay. In
Mhm.
order to fill your bladder up. Okay. Some thickers are also applied to the perineum, which is the area around the rectum and underneath the scrotum, and on the leg, just to measure your muscle tension as you're being filled and as you void. And then that's really all. Once that is all done, and it takes me 5 minutes to do, the patient is carefully, allowed to stand up with all these things kind of hanging, and they stand and they are get in front of an X-ray, a C arm, as we say. It's an
Mhm.
X-ray machine that we can, position them in front of so we can see their bladder. Okay. I hook them up to a monitor, which is our urodynamic machine. And then I go to my console and I start to fill up their bladder. Okay. Throughout this period, they're gonna talk to me and they're just gonna relax. I have a little funnel in front of their penis. Okay. And they have this, they're instructed to say, listen, when you do have a normal urgency or a desire to go to the bathroom, tell me all your symptoms. Okay. And at that point, what I will do is have them urinate without pushing into this funnel. Okay. Without pushing. But you may say, and a lot of listeners out there may say, but how do I do that if I have this catheter in my penis?
Right.
Well, the catheter is so thin. It's so thin that you will actually urinate around the catheter.
Mm.
Okay. So what this test provides me is the, the number one, a few things. It will tell me how large capacity your bladder is or how small capacity your bladder is.
Mhm.
It'll tell me the stiffness of the bladder called compliance. Okay. Because remember, we're measuring the pressure as it's slowly filling. Okay. And that pressure should normally be low as the bladder is filling. If
Mhm.
it gradually gets quickly high, then the compliance or the stiffness may be a problem.
Okay.
At that point, when the patient feels a real normal desire that they would normally go to the bathroom, I stop the filling process. Oh, and by the way, I fill them with a little mixture of a contrast agent and with normal saline. Okay. The patient will then, you know, in front of the funnel, urinate, and the urine will get caught into the funnel and the flow rate will be measured. Okay.
Okay.
So here we have this beautiful setup where I'm measuring the bladder squeezing pressure as this person is urinating, and I'm capturing the flow rate. Wow. Pressure versus flow.
Right.
All the while I'm actually taking a little x-ray of them urinating. Okay. So here's how it gets really good. You can see if it's a high pressure with a normal flow or low flow versus a normal pressure versus a low pressure as they're peeing. And I
Mm.
can combine that with the flow rate to come up with a diagnosis of, are they obstructed and how much? Is it equivocal, middle of the road, or are they clearly non-obstructed? In addition, lest we not forget our friend, the overactive bladder, I can see if they have overactive bladder. Okay.
Mm.
During their filling stage, I can see, oh, these wicked waves of like bladder contractions. When I see them, I will ask the patient, are you feeling anything? Yeah. How'd you know? I can see it
Yeah.
on the machine. I see
Right.
the bladder quivering. And then at
And
the
you
end,
can also see if it's underactive as well, right?
I can see when they're underactive at the point when they're urinating, if their flow is slow or normal and their bladder pressures are just not quite making it. Yeah. Yeah.
Yeah, that's great. Now, our patient with BPH. So here's oftentimes what happens with BPH and enlarged prostate is that they are obstructed due to their prostate, and they have either a slow stream or, and usually again their void residual is definitely sometimes 100 cc's or higher. Now they live like this for a long time, sometimes before they are diagnosed. How long can a BPH patient have BPH related LUTS, urinary symptoms, before the bladder starts being compromised, roughly?
Well, I don't think we know the answers to that question, but there are a bladder typically will not just conk out
Yeah.
when the urinary post-void residuals are pretty much low. A bladder will conk out if the post-void residuals gradually get higher and higher and higher and stay high for years. Okay.
Yeah.
So if the post-void residual is 125 or 150, that's elevated, but your bladder's not going to conk out because of that. Okay. So
Right.
I see, unfortunately, a lot of patients who come into my office and said, well, my doctor said that my bladder's going to fail if I don't do something quick. And I feel that's a
A,
little,
a little overkill.
it's a
Is a
little
little bit overkill.
dramatic.
Yeah, a little dramatic. Yeah.
Dramatic. It's really not going to, that's not really the case.
Yeah.
Yeah. Yeah. But I would say this is a process that goes on for years,
Right.
and it shouldn't you really should keep an eye on it.
So let me
It's
ask
like,
you this: obstruction, right? So BPH patient, they are in retention. They need to get catheterized. Is the mere fact that they got into retention, they're catheterized, will that automatically tell you without a urodynamic that they have a bladder that's compromised, or not necessarily?
that is a great question. Oftentimes people come to see me with a catheter and that exact same story, but I have no backstory on them.
Yeah.
I don't know if they've been going on for years and years with
Right.
like this large bladder. So, uh, yeah, that's somebody I would want to do urodynamics on because they're walking in my office. They could have a really tough, a weak bladder. And so it's important for me to do urodynamics because it gives the patient and their family some prognostic, indication. If, for example, if I look through urodynamics and I can see that they're clearly obstructed, well, then they're going to either be managed on medicine or they have surgery, and they're going to get a good feel that their improvement is going to be uh, very good. And there's an excellent, chance that they'll be back to normal.
Right.
However, if their bladder is completely shot and they still can't pee, well, then I have to coach them on certain things. Like, well, we can do salvage surgery to see if by opening up the outlet, it might help your bladder. Okay. And in other words, clear the obstruction for this weak bladder. It may urinate on its own. Okay. By just get rid of all the blockage, or or I coach them with some form of chronic bladder management for bladders that don't work. And that may be a chronic urinary indwelling urethral catheter. It might be a catheter which goes underneath the belly button into the bladder called a suprapubic tube, or it may involve, for the abled patient, a clean intermittent catheterization regimen where they do very quick, they do daily by inserting a thin little catheter in their bladder to empty their bladder 4 to 5 times a
Yeah,
day.
they do it themselves.
Correct. Yeah. Yeah.
Chris, I guess also my question along those lines is, once you at what point do you start damaging your bladder, with having obstructive urinary problems, likely from the prostate? I think you answered that, is you have to do urodynamic, and it depends on many factors. But let's just say there is some damage there to the bladder. Can that be reversed within time? So assuming that the obstruction is removed from a therapy or several therapies that we're going to talk about in a bit, can the bladder kind of become healthy again so that it can function properly on its own? Is that possible?
That I'm not aware of any kind of studies that show regeneration of bladder squeezing pressure, but I do know that um, if you're blocked and your bladder still works, it's worth giving any and every kind of effort to open up the resistance. Okay. It's
Mhm.
good for the bladder. And once that, if even if the bladder is somewhat sort of weakened, um, removing the obstruction, okay, is the best thing you can do for the bladder, whether it's surgery or with medicine. It's the best thing to do.
Sure. But in
There
terms
also,
of regeneration,
yeah,
depends.
regeneration.
We don't know. A little
We don't
iffy.
exactly know. What it probably is that the weakening has been done. Okay, but you can help out a weakened bladder. Now, the interesting thing, some damage done can also be in the form of a large bladder, what is called a diverticulum, which is a reaction to high grade obstruction over the years.
Mm.
And a bladder diverticulum is basically a reserve bladder that the bladder punches out of its wall to sort of deal with such high pressures. Okay. But the interesting thing is, while it's like a little storage closet of extra bladder tissue, it has no muscle. So that's a sign of a person who has had long term obstruction, and the bladder has developed this sort of escape route to kind of deal with the high pressures. Okay.
So
Without,
it's not a good sign.
it's not a good sign. And that could be surgically corrected if the bladder for diverticulum is a problem in the postoperative period. And
Understood.
that's an example of a really dramatic fix. Okay.
Gotcha. All right. Here's we have our BPH patient. We need to open up their prostate, right? So that
Okay.
hopefully their urinary function improves and their bladder hopefully regenerates.
Okay.
How do we do that? Now, I'm asking the question. I know some of the answer, of course, but man, every time I turn around, Chris, there's like another treatment for BPH, another surgical treatment. How many are there? Last time I counted is like 12 treatments these days. And like, how does one choose one from the other? And I know you've done a few, and I know you do aqua, and we'll talk about aqua for sure. But there's a lot of treatment, surgical treatments out there these days for BPH.
Yeah, there are. So when patients don't desire or don't tolerate or are no longer served by medical therapy, it's time to sort of, and they are obstructed, it's time to think about what kind of surgical approach one can do, or procedural approach, let's just say. The word surgical is not always appropriate.
Right, exactly. That's a good point.
A lot of it depends on the patient's goals. Okay. A lot of it depends on the patient's bladder function. Okay. And the prostate size. I say those are the very big things. Okay. So let's just take the surgical goals are Do I want to be done in the office? Okay. Do I want to be done under anesthesia? That's one, under anesthesia. Do I want to preserve my orgasmic function as best as possible? Okay. And by orgasmic function, I mean, do I still want to have a wet orgasm? Do I still want to have ejaculate fluid when I have an orgasm? The prostate size. The prostate size does factor in because the larger prostates, we would not do certain procedures. And the smaller prostates, again, we would not do certain procedures.
So
So,
how about urinary continence? Yes, I know no one would say, "Do I want urinary continence or do I not?" Everybody wants
oh,
urinary
exactly.
continence.
Do I want to take on the risk of urinary incontinence? And there are some procedures which really have low examples of that. Let me also add that bladder function is another consideration the urologist and the patient need to take into account. If the bladder does not work hardly at all, you probably would not do certain procedures expecting a good result. To maximize the result, you may want to do as much removal of tissue as possible if the bladder were really weak.
Mm.
Okay.
So what's
Yeah.
an example of what you would not wanna do if the bladder does not function at all?
You would probably not want to do a procedure which moves tissue of the prostate away. You would probably want to do a procedure which, which remove rather than, uh, um, either, squishes the prostate tissue away or
Right.
cuts a little line in. You want to have a more resective approach.
What are
You know,
some examples of, what are the names? You can call out the
well,
names.
I like to divide them into kind of two categories. One which don't resect the tissue too much, and
Which are those?
well, there's the I-10,
Uh-huh.
which is a device which is implanted into the patient prostate, which over several days will actually remold the prostate by cutting through fibers. Okay. And then it's removed after 5 days in the office, and it opens up the prostate tissue enough to help the urinary flow and drop the symptom scores after several weeks. There's another procedure called the posterior urethral lift or the Euro lift,
Yeah.
okay, which are the placement of little implants, okay, into the prostate, which effectively push the prostate tissue um, against itself, okay, clearing the way, one as if one were parting the curtains,
Right,
okay.
or like a stent, no?
That's not a stent, but they're just little tiny like pins or so, or implants,
Yeah.
which move the curtains away, okay, pinning them away from each other.
Sure, no
Uh, there-
resection happening here.
no, and there's another procedure, okay, called the Resume,
Yeah.
okay, which is a high intensity steam, which is focused into the prostate through a little steam injecting needle, okay, at several locations, so as to cause instant denaturing of the prostate tissue and
Yeah.
slow atrophy over several weeks. So all of these procedures purport to have excellent orgasmic function results so that men can be unblocked and have a good, retention of their orgasmic function.
Great. But
Those are,
you would not or you would recommend if they have a dysfunctional bladder?
I would be, well, there are certain kind of things where I'd be more careful. I probably would, divert patients with a very poor squeezing bladder away from them.
Yeah.
If a patient had a large growth of their prostate in a particular area called a median lobe,
Yeah.
I may sort of ask them to consider other surgeries. Okay,
Great.
those are the kind of things that I would sort of think. And also, if a person who's in flat out urinary retention, they've been in retention and they've had a catheter in for a long time. I typically don't have patients who have been in retention over a long time just go from this drastic scenario to a very minimally invasive office because
Right.
I don't feel like they're going to get as well served as with a resective category of treatment.
What are
Now,
some of those?
so those, there's actually many, but the gold standard, okay, which I love to say, is the transurethral resection of the prostate called the TURP.
The TURP. It's been around the
And
longest, right? It's sort of everybody's
it's
trained to
been
do
around
so.
forever,
Yeah.
and people get a little bit nervous when people call it by their casual name. It's called the
The
Roto-Rooter,
Roto-Rooter.
and
Who
that's
wants that,
scary.
right? Yeah.
Yeah, that's a scary feeling. I feel like there's this big, like, kind of screw that's going into,
Right.
like, the earth,
Right.
It sounds
Opening things
violent.
up there.
But actually, it is a wonderful procedure, and it with the skills resectionist, it can deliver a wide area of tissue opening for the patient. It can actually retrieve tissue for analysis. Okay, so, and there's another procedure like this called a green light
Yeah.
photo vaporization of the prostate.
Yeah.
Okay, now this is in a sense something similar to with a TURP. Okay, it is an instrument which goes through the penis. Okay, and the operator is looking through the lens, either with a camera or through it with their own eyes. And they can actually use this laser. Okay. It's a KTP laser, a neodymium YAG, and photo vaporize the prostate. Okay. With a very hot vapor. And there's no prostate chips to collect, but this does offer advantages. This laser can be used on patients with a lot of bleeding risk. So the person who cannot get off their blood thinners should have a green light, because it affords a very good opportunity to open up the prostate gland in a setting where they're not going to bleed out. They have a very low risk of it, because the green laser has a brilliant coagulative effect, while not only removing the prostate tissue, but also tearing down blood vessels that can bleed.
Chris, you're versed in green lights, right?
And very much so. Yeah.
Yeah. I remember. I mean, look, now I think you're considered as an Aquablation BPH,
No,
BPH
I don't really
urologist.
want to.
Wait a
I don't
minute.
want to corner myself into that.
Yeah, exactly.
I do a lot of different things. But we go further with other procedures. There's also laser procedures beyond the green light laser. These are laser nucleation type procedures. So people may have their prostate enucleated. Imagine the urologist goes into the penis while the patient's asleep. Of course, all of these are asleep. Okay, for this kind of resective approach, and with a laser, sort of actually cull out, if you will, the prostate as a whole organ. And then get this, push it literally into the bladder once it's been detached. Okay. And once that is done, another instrument is placed into the bladder safely. It's called the morcellator, which then sucks the prostate tissue and pulls it out of the patient's body, and has the tissue is analyzed by the pathologist. Now, you would do this with a patient with a large prostate, usually
What's the
larger
name of
than,
that procedure?
well, there are many.
Okay. Okay.
It all depends on the on the laser. If it's a holmium laser, it's a whole lap. If it's a thulium laser, it's a thulep.
Yeah.
It's a
Yeah.
diode laser. I'm not sure what that would
Yeah.
be.
Right.
Okay.
So
And
many
then,
choices.
and then there are other procedures for large prostates called a simple robotic prostatectomy.
Sure.
Okay.
Hold
Or
on that, because
okay.
I'm actually going to have our friend and colleague Jim Wysock talk about simple prostatectomies.
Okay, that's great. Now, one more thing I just want to add about a lot of these procedures. Okay. You may think, well, what's the story with the orgasmic
Yeah.
side effects of these resective procedures? Because it sounded like the other ones were like the way to go. Well, these resective procedures, you have a hard time holding on to ejaculation function unless the urologist is well trained in doing an ejaculation preserving green light, an ejaculation preserving TURP. But if they're doing a whole lep, a full lep, or a simple prostatectomy, they're not going to be able to preserve the orgasm wetness.
Uh-uh.
Okay. Now there is
Meaning
another.
they're gonna shoot blanks, or like they would say in the streets, or they would just not
Yeah,
have
dry orgasm. Yeah.
dry
Which for some
orgasm.
people, I mean, that requires a discussion, because what does that mean? Urologists will sometimes glibly state, oh, it's just less cleanup. And
Sure.
that might be true for some.
Right.
However, for others, it may not feel the same. And
Right.
patients may not like that. It may not feel as intense. And patients may not like that. So we have to really, in this day and age, be in a discussion to talk about it, and not just sort of you know, smile at the patient and go, well, it's less cleanup, because that may be an insensitive remark to a patient who, really
Who cares about their
has this
ejaculatory
pleasure.
function? Sure,
Okay. Like, I
sure.
also really
Go ahead.
advocate this aquablation thing because I haven't even mentioned that. May I or not?
We're raising the intensity of the desire for people to know. So, yeah, we're going to get to that in 30 seconds.
Sure.
In summary, so the patient, what they want is when they have BPH and they might be a candidate for a surgical procedure, they're looking at what, first and foremost, what's important to them, other than obviously resolving the problem: ejaculation, orgasmic ability to have an
Orgasmic
orgasm,
dysfunction. Yeah.
incontinence. Some procedures, perhaps procedures increase the likelihood of urinary incontinence more than others. Is that a correct statement?
Yeah, that is true. I think the procedures intrinsically in and of themselves, should not have a high level. In fact, they all really don't, but I mean, I think a lot of it depends on the surgeon, to be honest with you.
Okay.
But there are certain procedures which can get mighty close to the sphincter if you're not very careful. And that could be the simple prostatectomies or the enucleations. Remember, these are larger prostates,
Right.
and they're enucleated in both techniques. Okay, and this can get kind of close to the sphincter. The TURP and the green light and the aquablation, you can actually see the sphincter while you're operating, so there's less so of a risk. And we're talking not high risk. Okay, um, for aquablation, it's less than 0.1% risk of for green light. It's going to be low, less than 2 or 3%. For TURPs, probably similar. They do vary among studies, but they're low, low, low. People are very concerned about these things.
Excellent.
One must remember, okay, that if there is urinary leakage, that has to be further analyzed. Well, what kind of urinary leakage is it? Is it due to a sphincter damage or is it due to overactive bladder? And a lot of the times, if it's due to sphincter damage, quote unquote, or weakening, a lot of it can be actually improved with simple physical therapy
Sure.
post-operative, and the patient's back to normal.
Oh, good.
Okay. Yeah.
All right. So here we are. We're gonna talk about certainly what I think is your number one treatment right now. I know is patient dependent. So here's a 2023 systemic and meta analysis that says the following on aqua ablation for BPH. Actually, I just saw it this morning as I was preparing for our conversation. It says this: a meta analysis of the available data to date suggests that aqua ablation seems to improve LUTs in men with BPH while providing relatively preserved sexual function. The morbidity and perioperative outcomes after aqua ablation seem to be acceptable. So that's the main conclusion.
Mhm.
Tell us,
Right.
what is aqua ablation and why is it that you utilize this technique, this form of surgical treatment more than I believe others now at this point?
Well, when Aquablation came to NYU, it was pre-pandemic, and I did about 8 cases, and I was really intrigued by the patient's recovery, and how easy, actually straightforward it was. It is a robotic procedure. Okay, it's the first of its kind to do a transurethral robotic procedure. Okay, for the treatment of BPH. It started in 2017. It was FDA approved then. Okay, by a company in California. The company's name is called ProStep,
Mhm.
and Medicare approved it on all plans in 2020. A lot of then private insurers started to approve it as well. And now almost all the major carriers approve it.
Mhm.
So what is unique about this is that it uses a heat-free technology. I'll go into why that's important
Yep.
and it's an automated technology. Okay. And it's done through the penis with a water jet, which is the diameter of a human hair. Okay. The water jet is extremely powerful. You know, the guys, Geo, on the street with those blasters that clean up the old gum on
That
the sidewalks?
that's right. Yes.
That's about 6,000 PPI of force. The
Yep.
Aquablation jet is at 8,000 PPI
Wow.
approximately. Um, now,
Wow.
you
Okay.
may think that, wow, man, that sounds very destructive and dangerous. When a jet is in the air, it gets a little hard. It's very hard to control, like what you see with the guys on the street. But when a jet is underwater, it's profoundly controllable, okay, and predictable in how deep it can go and penetrate. So we won't go into the physics of this, but the aqua ablation folks have developed, okay, a tool through which this water jet can um, travel in a pendulum-like motion from from the beginning of the prostate all the way to the bottom of the end of the prostate,
Yep.
and sweep through it, cutting through tissue, um, and opening up the prostate tissue with a heat-free mechanism.
Why
The
is that important?
automated, yeah, the automated process makes a resection, okay, that would be approximately 2.5 hours with a TURP into a 10-minute procedure, which is unbelievable.
So you can do this procedure in patients within 10 minutes?
That is correct.
So
Now,
from the time the patient this is under, local anesthesia, of course.
it's not done under local. The patient is asleep. The patient is wheeled into the operating room, and there's a setup that takes about 20 to 25 minutes.
General
Okay.
anesthesia, I meant to say,
Generally, the
sorry.
patient
Yeah,
is placed into a position
yeah.
that is, we call it dorsal lithotomy. The legs are wide, the patient's asleep. And I first insert a probe, an ultrasound probe into the bottom, which is a unique facet of this procedure, which basically allows the urologist to view the prostate outside the body. So when I can look at on screen at the whole prostate, this is revolutionary. Now, instead of the traditional green light or TURP, where I'm operating through a straw, I now have the image of the prostate on the screen,
Mm,
all of it
yeah.
from cross section to lengthwise. And here I can tell the robot, I can tell the computer exactly what to do in terms of where to start that, water jet, where to end the water jet, where to go conservatively, where to go deep, and where to preserve the ejaculation sparing zone. So the water jet can open up the prostate in a very efficient way. And what I love about this procedure is that I get to do a personalized opening of each patient's prostate. Okay. And at the same time, uh, I'm able to preserve their orgasmic function 90% of the time. Can't guarantee it, but for folks that are very intent, I can always be much more conservative in my planning in order to preserve that one aspect. Um, and at the end of the procedure, I pull the robot out and then I go in and I cauterize the bladder neck in order to control any bleeding that happens after the water jet passes through. Now, the fact that it's heat free is a big, I think, deal. What you do is um, uh, you don't have that thermal energy passing through very sensitive areas like the ejaculation ducts. So I think this is why you have a excellent report card in terms of ejaculatory sparing for this surgical therapy.
Hmm.
Additionally, one more actual thing about the ultrasound in the bottom. What this does, it allows me to see more prostate than I would be able to see if I were to just go operate through a straw, if you will,
Mhm.
with the traditional procedures. So I can get more tissue out of somebody and have the robot do it for me.
Well,
And
that's,
so, yeah, it's remarkable.
it
So what
is, and is the goal, I mean, aqua ablation has not been out long enough to have long-term studies,
oh
but
no, we
we
do have 5-year studies.
right. What we well, 5 years is probably, well, I'm looking for 10 and 15 years, which we'll get at some point, and the reason for that, Chris, is because oftentimes with the other procedures where they've been around longer, sometimes we know that the recurrence of BPH happens within 5 to 6, 7 years.
Okay.
What do you suspect is the recurrence rate? I know just from clinical experience, perhaps that it would be from aquablation. Is it any different? In other words, before somebody will have again obstructive urinary problems and require another procedure, if not the same one?
Yeah. Yeah, that's often kind of this is where aquablation becomes, has its own kind of selling point. Um, people have looked at the comparisons between the medical or surgical retreatment rate, okay, between a TURP, which is the gold standard everyone's trying to beat, and the aquablation, okay? And when looking at the data, okay, over hundreds of patients, the retreatment rate for patients who have had a TURP was approximately 12%. Those with the aquablation, now we're talking 5 years,
Right.
only 6%.
Okay.
And that's a huge difference.
4% difference. Okay. So that
Now,
doesn't mean that
it's
those
simply,
with aqua don't have a situation where that tissue regrows and it can cause problems, but is a lot less than TURP, or at least 40% less than the TURP.
you're going to have a lesser treatment rate if you have an aquablation. Yes. Now, what's interesting about aquablation, there's no size limit when it comes to how big can you do a prostate. You can do as
That's
big
a
as you
great
can.
point. Great point.
If you have a large prostate, you can do it. If you have a small prostate, you can do it. It's
Right.
automated, it's robotic, it's personalized, and it can spare orgasm better than any resective treatment.
So prostate size doesn't matter. I know it matters for other treatments, but not so
Yeah,
much
you
for
don't want
aqua.
to interpret for a large prostate. For large prostates, another procedure which we didn't really talk about, but I just want to mention it in order to help patients with large prostates or anybody who really wants relief but doesn't want surgery, is the prostate arterial embolization, where
PAE.
an
Yeah.
interventional radiologist can go through, okay, an artery and actually thread it all the way down to the prostate artery and put a little material, little beads that cut off the blood supply to the prostate gland bilaterally, bilaterally. And what this does is over time is it atrophies or shrinks the prostate. This has a very good ejaculation sparing rate. Okay. Um, and you do this for, you can do this for huge prostates. Okay. Very large prostates or, enlarged prostates. I wouldn't do it for a prostate that's very small, wouldn't be appropriate for this procedure, but that is something that some patients do.
Chris, who is not a good candidate for aqua ablation therapy?
Um, a person who is on blood thinners, okay. I'd like to step away from that a little bit, but I can definitely do patients who are on aspirin. Daily
Mhm.
aspirin is not a problem for me.
Okay.
I also would say patients with tight and small prostates are probably not the best to study for aquablation. Did look at patients 25 grams or and up. So I would say to the patient under 25 grams would probably not be appropriate for an aqua ablation.
Chris,
Also,
when was the
patient,
last time you've seen a patient? So 25 grams for the audience is pretty much the size maybe of a 25-year-old, the size of a prostate of a 25-year-old or so. Is there a guy coming in with BPH with such a small prostate? Have you seen that?
oh yes, I had. Oh no, no,
Wow.
that's
Okay.
really great. It may not be the size of the prostate, but it might be the angle of the prostate
Sure.
opening. Okay. And that's something we call primary bladder neck obstruction or primary bladder outlet obstruction. Oh, and yes. And those can be patients with severe obstruction. Okay. So it's not all about size in urology. It's what I'm feeling. It could
Size
be even
doesn't matter all the time, does it?
no, even small prostates can be really tight, angry, and pernicious. So you got to be kind of on guard for anything that comes at your way. Don't just say, I love what I do.
Yeah. No, it sounds
Yeah.
like it for sure. We know
I'm
that.
going to say that I would probably fancy myself more, not a general urologist.
That's right.
I'm more of a specialist in the area of male body dysfunction.
That's right. That's
This
right.
is what I do.
Um, what more can you share with us about aqua? Is aqua ablation the most recent form of surgical treatment for BPH? Is there one that's even uh, newer than aqua?
Well, there's the iTin, which is the device I mentioned earlier, which is office based. It can open up smaller prostates.
Yeah.
Okay, and that's probably one of that's the latest. Okay, but more treatments are in development. But the aqua ablation, let's see, it is growing across the country. More and more people are buying the robots across the country. New York City itself, just last year had, I guess, single digits in terms of who had the robot. Now it's double digits, and it's spreading the Northeast. It's all over the Midwest and in the West Coast. So it is growing. People are sort of getting on to the fact that you can have a deobstructive procedure done and have the highest rate of orgasmic preservation.
Yeah.
I think that's I think people are starting to talk about this more. Now there is a growing number of people who are doing or programs that are doing holmium lasers, the enucleation.
Okay.
And while this is also a venerable procedure to open up large prostates, it doesn't preserve orgasm too well. Okay. So I think that more and more people are open to talking about sexual preservation, the more they're going to find out that aqua ablation probably sits better with them than these other types of procedures like the holmium enucleation or thulium enucleation. And I used to do that.
Do
I
we
had,
get tissue from aqua? Is there any tissue that one can analyze for prostate cancer if they choose
yes,
if they want
yes,
to?
yes, because when I go in to do the focal bladder neck cauterization, I do take some swipes of tissue and send it out.
Okay,
That
good,
is
good.
correct.
Um, what else? I mean, final thoughts on aqua ablation. I think you were very thorough. I think that you were very thorough on the whole process of how to differentiate with between BPH and other urinary problems. So,
I
what
think
are
if
some
they should
final
go,
thoughts?
I think if people want to learn more about it, they should go on aquaablation, okay, .com.
Okay,
And Procept has a wonderful website. Okay.
I'll put it in our show notes as well.
Oh, that's great. They can educate themselves and they can even find an aqua ablation specialist nearest to them.
Chris,
Okay.
how many? This is a scenario like any other surgical procedure,
Mhm.
where I would assume the more you do, the more experienced you are, the better you are at it, like anything
Right.
else. How many have you done? So if somebody comes to you, Dr. Kelly, how many of these have you done? And for obvious reasons, so how many? What's the answer?
So, so just to put it in context, we NYU Langone Health bought the aqua ablation machine, and I started last year in May 2022.
Yeah.
Okay. So since then, I've done actually, as of yesterday, 151 or 152
Wow. Okay.
of them. So I have a good experience still, compared to my esteemed colleagues out in Georgia and, in New York City,
Yeah.
not as much as them, but
Yeah.
I'm loving it. And I think what's so great about it is that once you've done five of them, I mean, your doctor is up and running. It's really, it's a, it's an intricate process, but it's quite easy to learn and to be very good at quite early on.
So it
Okay.
doesn't require such a steep learning curve, right?
That's a great point. It doesn't. There are other procedures like enucleation with the lasers, a holmium boom. It is a steep learning curve. And God bless those great urologists that do that. It does take a while to get sort of, um, to cut your teeth on that kind of a procedure. I know that very well because I used to do them.
Yeah.
But with aquablation, it's different. It's different. And that's what's so good about it because people are going to be able to find urologists who can do this procedure. And it's not going to be so far and few between in the country.
Great. Chris, thank you so much. How can people find out more about your work and any websites or anything? We'll put it on the link. on the
No,
show in
they
the
can
show
go
notes.
at NYU Urology,
Okay,
and they'll find my name on a list of providers there.
great. Chris, thanks again for your time. I really appreciate it. Thanks for being on and educating everyone on BPH and aquablation. I appreciate it.
Have me back. We'll talk about prostatitis and pelvic.
Oh, okay. Be
I'd
careful
love
what you
to
ask
too.
for. Be careful what
Yes,
you ask for.
yes, exactly. No, we'll do a lot of stuff. And this was a pleasure to be here. I really thank you for giving me some platform to talk about everything. Okay.
Thanks, Chris. Have a great day.
Thank you.
See you next time. Thanks for tuning in to this week's episode of the Dr. Geo Podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Geo Espinoza ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.